When people hear symptoms like depression, anxiety, hallucinations, delusions, unusual behavior, or worsening memory, their first reaction is often, is this a psychiatric illness? And honestly, that's a very common and sometimes very appropriate assumption. These symptoms can absolutely require professional psychiatric care. But there's another possibility that often gets overlooked. Sometimes the problem isn't primarily psychological. Sometimes it's biological, a disruption in a metabolic pathway in the body that ends up affecting how the brain works. In medicine, these conditions are often grouped under inborn errors of metabolism, or IEMS, or genetic metabolic brain disorders, or GMBDS. What makes them tricky is that they can mask themselves as psychiatric conditions, so patients may be diagnosed with a primary mental health disorder, while the underlying metabolic issue goes unnoticed. For example, problems in folate-related metabolic pathways can sometimes lead to symptoms that look very similar to psychiatric disorders, and in some cases, those problems are treatable. But here's the key point. Folate isn't just one simple substance. It comes in different forms, and different disorders can disrupt different steps of folate metabolism. So the right treatment really depends on which part of the pathway is affected. Part 1. Metabolic psychiatric symptoms that may respond to folate-based treatment. Some inborn errors of metabolism, or IEMs, can cause what we might call metabolic psychiatric symptoms. People may show clear psychiatric signs, yet in the clinic they're sometimes diagnosed as having a primary psychiatric disorder, and the underlying cause is missed. But in these cases, the symptoms aren't just psychological. They can happen because a metabolic pathway in the body isn't working properly, which then affects how the brain functions. And when treatment targets the metabolic abnormality, symptoms can improve. Today, let's look at several conditions linked to folate metabolism that can present with psychiatric-like symptoms, including FOLR1-related cerebral folate transport deficiency, FOLR1, CFTD, CBS deficiency, cblCDisease, and MTHFR deficiency, FOLR1. CFTD FOLR1 is caused by a problem with the folate receptor, which leads to low levels of a key folate form, 5-MTHF, in the cerebrospinal fluid. Symptoms often begin around 2 years of age and may include developmental delay, speech and intellectual impairment, and seizures. Without treatment, children may develop severe cognitive and motor difficulties. CBS deficiency. In CBS deficiency, homocysteine builds up in the body and can affect brain function. Patients may experience symptoms such as seizures, ADH, D-like behaviors, anxiety, depression, and sleep problems. cblCDisease. cblCDisease involves a disruption in vitamin B12 metabolism, leading to elevated methylmalonic acid and homocysteine, which can harm the brain. In infancy, symptoms may include feeding difficulties, low muscle tone, and seizures. In adult-onset cases, psychiatric symptoms are more common, such as behavioral changes, social withdrawal, and hallucinations. Late-onset cases can also present with cognitive decline and memory problems, and may be misdiagnosed as a psychiatric disorder or even dementia. MTHFR deficiency. MTHFR deficiency happens when the enzyme doesn't work well, so folate can't be converted efficiently. This can affect neurotransmitter pathways and myelin formation. Severe cases in newborns or infants may involve seizures and developmental delay. Milder or later onset cases may show up in adolescence when someone seeks help for mood symptoms, anxiety, or schizophrenia-like symptoms, and they may be misdiagnosed as having a primary psychiatric disorder. Overall, in these conditions, psychiatric symptoms can be closely tied to the underlying metabolic disruption. With timely, targeted treatment, including folate supplementation when appropriate, symptoms may be significantly relieved. Part 2. How folate helps treat these metabolic psychiatric symptoms. Folate is not a magic psychiatric pill, but in some genetic metabolic brain disorders, or GMBS, it really can be one of the keys to treating the root problem. In conditions like FOLR1-related cerebral folate transport deficiency, FOLR1 CFTD, CBS deficiency, cblCDisease, and MTHFR deficiency, folate-based therapy may help relieve psychiatric symptoms, either directly or as supportive treatment. Most people know folate as a prenatal vitamin, but in metabolic disorders, the folate family, folic acid, 5-MTHF, and folinic acid, Leucovorin, isn't just a supplement. It can act more like a tool to help restore a disrupted metabolic pathway. In other words, you're not simply taking a vitamin. You're trying to restart a stalled biochemical cycle. That's why folate therapy is not one size fits all. Different disorders require different forms of folate, and using the wrong form may be ineffective, or in some situations may carry risk. So, what are the main forms we're talking about? There are 3 that come up most often: folic acid, 5-MTHF, 5-methyl-tetrahydrofolate, and folinic acid, also known as Leucovorin. They don't work the same way, and their roles vary depending on the disorder. Folic acid. Folic acid is the most common oxidized form found in supplements. But once it's in the body, it needs multiple processing steps before it can become the active form, 5-MTHF. 5-MTHF is the active form that directly supports methylation reactions. These reactions are important for brain function, especially neurodevelopment and myelin maintenance. Folinic acid, or Leucovorin, can act like a backup source in some situations. When transport or processing is limited, it may help feed into the active folate pool more easily. But it also has limits, especially when MTHFR function is reduced, because folinic acid may not fully replace what 5-MTHF does. Choosing the right form for the right metabolic problem. Different metabolic problems call for different folate forms. For FOLR1 CFTD, the issue is basically that the entry route into the brain isn't working well. Folate can't reach the brain effectively. In that situation, folinic acid, Leucovorin, is often a better fit because it can help bypass that transport problem and improve symptoms. For CBS deficiency, folate mainly helps support an alternate pathway for handling homocysteine, which may help reduce related risks. In this context, standard folic acid may provide useful support. For cblCDisease, the primary problem isn't folate deficiency. The core issue is impaired activation of vitamin B12, which lowers methylation capacity in the brain. So folate therapy here is more supportive, helping the folate cycle run more smoothly. But the most important step is still to address the B12-related pathway. And finally, in MTHFR deficiency, the problem directly leads to low 5-MTHF, which can affect brain function. In many cases, the most effective approach is to supplement 5-MTHF itself, rather than folic acid or folinic acid, because those forms still require MTHFR dependent steps to become 5-MTHF, and that step is exactly where the pathway is impaired. Takeaway. So overall, folate therapy isn't just taking folate. It's about matching the right form to the right metabolic block. Understanding the mechanism is what allows clinicians to choose the right folate type, dosing strategy, and treatment target. And that's why folate should not be used casually for psychiatric symptoms in general. When psychiatric symptoms are involved, identifying the underlying cause is the most important step. Part 3. When folate-based therapy is appropriate and when it isn't. In some metabolic conditions, like FOLR1-related cerebral folate transport deficiency, FOLR1, CFTD, CBS deficiency, cblCDisease, and MTHFR deficiency. Folate deficiency or a blocked pathway can interfere with brain chemistry. When the brain can't get enough folate or can't use it properly, this may disrupt neurotransmitter synthesis and methylation and can contribute to symptoms such as autism-like features, seizures, cognitive impairment, and mood instability. In situations like these, folate or active folate forms, such as folinic acid, leucovorin, or 5-MTHF, 5-methyltetrahydrofolate, may be used as supportive treatment to help restore methylation-related processes and neurotransmitter production, which can improve symptoms. But these 4 disorders aren't the only ones. There are other inborn errors of metabolism, IEMs, that affect folate transport or 1-carbon metabolism and can also present with similar neuropsychiatric symptoms, sometimes with a response to folate-based therapy. Examples include hereditary folate malabsorption due to PCFT deficiency, DHFR deficiency, dihydrofolate reductase deficiency, FTCD deficiency, and MTHFD1 deficiency. What these conditions often have in common is a shortage of 5-MTH in the brain, or an insufficient supply of 1-carbon units that can lead to impaired methylation, myelin injury, and abnormal neurotransmitter synthesis, showing up as developmental delay, seizures, psychosis-like symptoms, and sometimes autism-like features. For these disorders, high-dose folinic acid, leucovorin, or 5-MTHF, can be a key part of treatment because they may help bypass the damaged step and raise folate availability in the cerebrospinal fluid, CSF, which can improve related symptoms. Not every metabolic psychiatric presentation is folate-related. At the same time, it's important to be clear. Not all psychiatric symptoms are caused by folate metabolism problems. There are many different metabolic disorders that can cause psychiatric or cognitive symptoms, but the treatments are completely different. For example, cerebrotendinous xanthomatosis, CTX, is caused by a bile acid synthesis defect, and treatment relies on chenodeoxycholic acid, not folate. In Wilson disease, psychiatric symptoms are addressed by using chelating agents to remove excess copper. In hereditary hemochromatosis, depression and cognitive issues related to iron overload are treated with phlebotomy to reduce iron burden. In acute porphyrias, episodic psychiatric symptoms, like hallucinations or delirium, are treated with intravenous hemine and by avoiding triggers. Other disorders, such as phenylketonuria, PKU, some mitochondrial diseases, lysosomal storage disorders, and urea cycle disorders, can also involve psychiatric symptoms. But again, each condition has its own treatment approach, such as protein restriction, ketogenic diets, enzyme replacement therapy, or ammonia scavenging medications, and folate can't correct those underlying problems. Takeaway: so folate-based therapy in metabolic psychiatric symptoms should only be considered when there's a clear diagnosis showing that the cause involves folate transport or 1-carbon metabolism. If folate is taken blindly, it may offer no benefit, and in some cases, it can even distract from the real cause and delay the right treatment. Part 4. The future of folate-based approaches in psychiatric symptoms. As we learn more about inborn errors of metabolism, or IEMS, we're seeing more situations where psychiatric symptoms can improve with targeted metabolic care. As of 2025, 1,564 different IEMs have been identified. That matters because it suggests that within everyday psychiatric practice, a subset of patients may have symptoms driven by an underlying metabolic defect. So the future isn't about giving everyone folate. It's about precision screening and individualized treatment. When a folate pathway disorder is suspected, we may need a broader workup, including comprehensive biochemical and genetic testing, and in some settings, even research tools like untargeted broad-spectrum metabolomics. Clinically, if someone has psychiatric symptoms that are hard to explain, especially when they also have cognitive decline, seizures, or progressive neurological deterioration, and their plasma homocysteine is elevated, a folate-related IEM should be considered, and a metabolic evaluation is warranted. By checking markers like plasma homocysteine and methylmalonic acid, we can start to tell whether the problem is a methylation pathway disruption, such as MTHFR deficiency or cblCDisease, or something else. And measuring CSF5-MTHF gives a direct window into folate status in the brain. It can be an important clue when a folate transport problem is suspected. You can think of these biomarkers as a kind of diagnostic dashboard that helps narrow down the cause. If CSF5-MTHF is low, but peripheral folate looks normal, that points more toward a problem with folate transport or utilization in the brain. If homocysteine and methylmalonic acid are both elevated, that suggests cblCDisease or another vitamin B12-related metabolic issue. If methionine is high, that supports CBS deficiency. If methionine is low, that may point to a remethylation defect. Once we identify a subgroup of patients and they show a clear response to folate-based therapy, they should be included in more systematic research. That means collecting standardized clinical and biochemical data, such as changes in seizure frequency, cognitive testing, or improvements in homocysteine and CSF folate markers. These data don't just help evaluate effectiveness, they can also point toward new genes or new disease mechanisms. And it's worth remembering, the IEMs we recognize today may be only the tip of the iceberg. Many metabolic genetic defects likely remain undiscovered. As metabolic mapping and diagnostic tools keep improving, we may identify more previously unrecognized IEMS, and even define entirely new disease categories. That's why collaboration between clinicians, researchers, and patients is so important. Under proper medical supervision, clinicians can guide truly mechanism-based treatment, and researchers can turn meaningful treatment responses into scientific leads, rather than leaving patients to try therapies blindly. This approach could accelerate the discovery of more folate-related, treatable IEMs. Overall, the future of folate in metabolic psychiatric symptoms is promising, but only when it's grounded in precise diagnosis and solid evidence. By tightly connecting mechanism, clinical care, and research, we can better unlock folate's potential in complex psychiatric presentations. If you're interested in more stories about how inborn errors of metabolism, also known as IEMS, can affect mental health and lead to metabolic psychiatric symptoms, you can check out the full written version in the Sunyi section.